All right, thank you so much, IVHEM, for bringing the World Hepatitis Alliance, and thank you for the privilege to present. So I'm going to speak about stigma reduction, elimination program led by community, and I'm Danjuma, Adda, the president of the Alliance. So, well, this is just about the World Hepatitis Alliance. For those who don't know, we are an international organization that is driven by people with lived experience. And to that effect, I can say I'm also someone with hepatitis B. And we are the face behind the data. We are the face behind all the numbers. And we represent the people that are affected by hepatitis globally, led by people living hepatitis who advocate at global, regional, and national levels to keep hepatitis on top of the health agenda. We raise the voices of the people, communities affected by viral hepatitis. So we represent the communities affected by hepatitis. Now, the WHO has presented us data. I'm not here to really talk about data. But if we look at the hepatitis goals of 2025 to 2030, with 2025 being the midterm, 2030 the goal, the target of elimination. We've seen this data over and over, especially from the region where I come from Africa, where just probably 2% diagnosed with hepatitis B and 0.1% of people on treatment with hepatitis B. And for the achievement of hepatitis C is mostly attributable to one country, which is Egypt. So how do we really bridge this gap of the cascade of care for hepatitis and HIV, for hepatitis B and C? That is a major challenge, and that is something that even at the level of WHO, we keep cracking our head and asking, what can we do differently? Now, hepatitis B and C is both a chronic and infectious disease. So while clinical care has improved over time, community care has not achieved or received much attention. It is therefore really important to strengthen community involvement in eliminating viral hepatitis B and C. We talk a lot about learning from HIV. We talk a lot about integrating hepatitis B services, using learning from HIV, but we seem not to really adopt or really replicate the success achieved by the HIV. I was speaking with some HIV advocates, and they told me, Danjuma, you guys are where we were 25 years ago, where the community voice was going down, but they made advocacy, they made noise, and they were given the opportunities to be in the space where they also drive intervention. So a lot has been achieved in clinical care, but very little has been achieved in community care to bridge the gap between the cascade of care. Look at the alarming difference of those diagnosed, those on treatment, and how do we get to elimination? So we need to also really walk the talk in strengthening the community component of care towards achieving viral hepatitis elimination. So patients and people with chronic hepatitis B are the most underused resource in the healthcare system. Pardon me to say that, but I think that is really the reality. And we keep, like I still want to bring back the issue about HIV. What has helped the HIV community, what really moved the needle in HIV response was the empowerment of advocates and activists, was the active involvement of HIV community and group in case finding, in retention in care, in peer navigation. But very little of this is being done in the hepatitis space. So evidence from patient-centered care through the HIV community have demonstrated better quality of care, as well as potential long-term cost effectiveness. And if you look at the presentation by Philippa, that for a strategic shift and to really attain the goal of elimination, decentralization has to take place and services need to go closer to the community. But so hepatitis B and HIV community are struggling to get the support they need to become equal partners in care. Each time we bring the voice of community and we keep hearing, we don't have community groups. There are no hepatitis patient groups. There are not existing groups, or they don't have the capacity to implement activities. Well, that is a bit tokenistic anyway. So to make real progress, we need to make patient empowerment and engagement a priority. Community-led and community-based service delivery are an integral part of effective primary health care, and they are essential to complement facility-based services. And I'm happy that that is also the approach of WHO, but it's unfortunate, especially from regions like LMIC, so most of African area, you discover there's very little involvement of community groups, especially the hepatitis B or C. Like I mentioned, yes, we're not saying It's no longer a chronic disease condition. We're not saying take it away from the specialists, but we're saying much has been achieved as a chronic disease, but now can we look at the infectious disease part, which now involves the community component, which now involves the active community engagement, which now involves engaging the affected populations in service delivery. So community-based and peer-led approaches bring services closer to people. I don't need to preach to the choir or preach to the converted, because we all know this. A lot of success has been achieved in the HIV spectrum because communities were involved in every aspect of service delivery. But it's really disheartening to say that majority of national programs, either through guidelines development or guidelines training or guidelines dissemination, I was discussing with my colleague from Nigeria, that majority of governments do not involve communities, do not involve affected populations, do not involve the affected people in driving service delivery. So community-based, but then community groups need to be empowered with a wider choice of interventions, including greater possibilities for self-care and autonomy. Now, why is there a gap in linkage to care and hepatitis B? Of course, like we keep saying, it has always been a chronic disease case with the hepatologist. The patient goes to the hospital, and I speak as a person who lives in hepatitis B. And the patient is told you don't need treatment, go back, and he gets lost. He doesn't ever comes back. Right outside the gate of the hospital, he meets the traditional medical person who promises him cure, who has more immediate solutions. And a lot of these activities happen in the community. So it's very important to involve community in relinking people to care and retaining people in care. It's very important if we must achieve elimination of viral hepatitis. Unless we involve community groups, ending stigma and discrimination will be difficult. Unless viral hepatitis groups get involved and actively participate in service delivery, like the HIV community, elimination will be difficult. So, yes, this is a bit maybe harsh to say that we have so much research studies, we have a lot of research, but what we need now is to scale up service delivery. I'm not against research, we're not against pilot studies, but we need to scale up more testing, we need to scale up more interventions, we need to get more pills in the stomach of patients, and that will happen only if there's more interventional studies, more operational interventions going on rather than just demonstration projects. I'm not against demonstration projects, but we need to scale testing and treatment. More pills need to be in the stomach. If Egypt did not screen 60 million people, they will not have achieved the goal tier of elimination. So let's do more of the services before we can really achieve elimination. And communities need to be involved. Viral hepatitis communities lack the agency, and that is where the challenge is. If you look at even trainings, only clinicians get trained. Only researchers get trained. The advocates, the patient groups are not brought into the room for training to understand the little science about hepatitis. So most of the community groups and patient groups lack the agency, lack the opportunities to be actively involved in national responses. I'm saying this especially with respect to national responses, national programs, either guidelines development, either treatment guidelines program, whatever it is. It's important to bring the patient for whose benefit these programs are meant for, to be at the table, to be in the room when all these trainings are going on, to own it and then to move it. And this needs to change. There's need for paradigm shift. So even if the research, patient group needs to be involved, treatment guidelines, training, whatever it is, patient groups and community needs to be involved. So to improve access along the cascade of care, community groups must be actively engaged by national programs, and the gaps in diagnosis can only be bridged when we now increase the engagement of community groups to improve peer-to-peer navigation, to bring peer support, to bring the escort services, to bring the differentiated service models, to bring about community-led monitoring. Egypt achieved this because they took service out of the right to the communities. They had village champions, they had village promoters, and these were community people. These are real natives and people that live in the communities, and they made this change happen. So we need also maybe from WHO community-based guidance tools to maybe also give a framework on how community involvement also could be strengthened. So ending stigma will require active participation of clinicians, of course, patients and the community. While the hepatologist does a wonderful job of taking care of the liver, taking care of people with end-stage disease, we need to prevent that from happening. And that is only when community are involved. That is when communities get actively engaged in the peer navigation, in bringing patients that have been lost to follow up, because they need to relink people to care. So clinicians also can help identify champion patients and empower them with the right skills. Due to the high volumes of people that will be initiated on treatment when the HPV guidelines release, there's an urgent need to empower community groups with the right information. So national programs should develop information training guidelines, should develop also information materials for community groups to empower community groups with the right information, to empower community groups with the skills and resources to provide needed services, so that people don't rely on Dr. Google alone, but people should have, so that there should be, trusted information sources. I can attest you, we see from example of COVID, where there are a lot of myths and misconceptions, so many channels of communication, but national programs should develop trusted information sites where people could refer to, where people could go to for information, and it helps to really guide and reduce stigmatization or break down barriers at the community level. And with the new guidelines coming up, it will be very important to bring peer navigation and retention in care. If more people are diagnosed, more people need to be retained care. That is where community groups will come in. So community groups should be involved and provided with grants to support their work. It's really disheartening to see that most of the hepatitis patient groups lack the agency because there are no resources. I was the regional board member for WHO 2014 to 2016. I can tell you that about 30% of our active, motivated patient groups have dropped off because there's no funding. Passionate people that are ready to really put their life on the line, but there's no funding. Give 10, 15 groups just $10,000, $15,000 that may not organize a coffee meeting here. They can do a lot. Sorry, we do apologies to all that happened in the Western world. They can do so much in screening. They can do so much in linking people to care. They can do so much in retaining people in care. We need the traditional method of the town hall meetings, the town criers, to mobilize communities, to mobilize people. Without this, we're going nowhere. So a lot of the patient groups and advocates lack the resources. They lack the funding. So we need to do a lot to empower the community groups, empower patient groups, so that they have the resources and the opportunities to implement programs to eliminate hepatitis across the world. So this is also what we have as a World Hepatitis Summit coming up 2024. I hope you sign up, and we'll see you in Lisbon. Thank you.